Welcome to the Deep Dive, the show that cuts through the noise and gets you straight to the insights. Today, we're going to challenge a common assumption. What if we told you that health isn't just about whether you're sick or not, and that your personal definition of health might be, well, vastly different from your neighbors, maybe even changing with your age, gender, or social class?
That's a fascinating thought, isn't it?
We're about to dive into a really interesting area where, personal experience and scientific understanding truly intertwine.
It is. It's a complex and, frankly, crucial topic. We're taking a deep dive today into promoting health and well-being. We're drawing from a pretty comprehensive source that unpacks, well, everything from your individual health choices right up to broad global public health policies. It's really about getting you well-informed quickly, cutting through the jargon.
And our mission for you, our listener, is to give you that shortcut, a shortcut to understanding this intricate world. We're going to explore some surprising facts, different perspectives, and really arm you with key insights. Insights on how health is understood, how it's influenced, and how it's promoted at every single level, from your own genes, like you said, all the way to your wider community.
Get ready for some aha moments, hopefully.
Yeah, exactly. Hopefully it'll change how you see health all around you.
Yeah.
So let's unpack this. Where do we start? How we even define health?
That's the perfect place to start, because it's far more fluid than many people realize. The whole concept of health and well-being is incredibly nuanced, and it can shift significantly, from person to person. It gets shaped by our individual experiences, our professional backgrounds, even unique personal insights we might have.
Okay.
And there's a common pitfall, actually. Some research points this out.
Yeah.
We often see professional medical knowledge as, well, the scientific truth.
Right. The expert view.
Exactly. While a person's everyday understanding of their own health, what we call lay knowledge, sometimes gets dismissed. Dismissed as just folk wisdom or maybe personal opinion instead of valuable insight in its own right.
That immediately flags a kind of disconnect, doesn't it, between the professional and the personal?
It does.
But I remember reading about a large UK survey, I think it was back in 1987, that really challenged that idea.
Plaxter's work.
Yeah, it found individuals defined health as much more than just, not being sick. They included things like physical coping, psychological coping, even overall psychosocial well-being as really key components.
Absolutely. It's a much broader picture.
And there was an interesting twist, too. Men in that survey often specifically related health to fitness, to physical strength, which just shows how gender can shape our very definitions of what it means to be healthy.
And that multidimensional, constantly shifting understanding of health means that health promotion itself has to be incredibly dynamic. It can't be static.
It has to keep up.
Exactly. It's always responding to an ever-changing environment. I mean, think about the climate crisis, right? Or the emergence of new illnesses, or even just shifting political priorities.
That's so true. This isn't something set in stone. We're talking about things like emergency response planning for extreme weather events now. That's public health.
Definitely.
Or the ongoing challenge of preventing communicable diseases, especially now with so much international travel.
A constant concern.
Or tackling an issue like loneliness, which we're only really starting to recognize as a major public health problem.
Yes, the social dimensions are crucial.
And think about social media. Just a decade ago, using it for health info wasn't really a thing, was it? But now it's a critical tool in a lot of modern health strategies.
It's completely transformed the landscape. So if health is this complex, this shifting thing, what does public health actually mean in practice? And, crucially, how does it connect to those glaring health inequalities we see?
Good question. What's the standard definition?
Well, the World Health Organization offers a really powerful one. They call public health the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society.
Organized efforts of society.
Yeah.
That's key. It's collective.
It's collective, exactly. It's rooted in the idea that health isn't just about what you do individually, but what we all do together as a society.
And what's really striking when you look at the history is how much the landscape of health has changed.
Oh, massively.
Over the past century, we've gained a lot of healthy years, right? Life expectancy is up. But now, the biggest health challenges, the main causes of death and long-term illness, are increasingly things like heart disease, diabetes, cancers, non-communicable diseases.
Rather than the infectious diseases that used to be the primary threat.
Exactly, which means a massive shift in focus for public health efforts.
And this brings us right to the doorstep of health inequalities. It's a term you hear a lot, but what does it actually mean?
Yeah, let's break that down.
It basically refers to the undeniable fact that different groups in society experience different levels of health. It's not
Hmm.
random. We often measure these disparities by looking at things like mortality rates, how long people live, the prevalence of disability.
And are there specific examples?
Oh, definitely. A stark one is lung cancer. It's significantly more common among the most deprived groups in society compared to the least deprived.
That's a clear link to social conditions.
Absolutely. And a landmark piece of work, you mentioned it earlier, the Black Report from way back in 1988, really laid this bare.
Still so relevant, though.
Incredibly relevant. It showed that health is absolutely not evenly distributed. It's strongly influenced by social class. Lower classes consistently had worse health outcomes, shorter lifespans.
And that hasn't gone away, has it? I remember the Marmot review more recently.
Exactly. Marmot's 2020 review echoed this. It showed that preventable illness and early death are highest in the poorest geographical areas, while the wealthiest areas have the best outcomes. It's this persistent gradient, deeply embedded in our social structure.
A gradient, that's a good way to put it. It's not just rich versus poor, it's steps all the way down.
Precisely. And this is where a model like the rainbow model of health by Dahlgren and Whitehead is so helpful visually.
Okay, paint us a picture.
Imagine concentric circles, like ripples in a pond or a rainbow. At the center, you have individual factors like age, sex, genetics.
Mm-hmm.
Then the next layer out is individual lifestyle factors.
Diet, exercise, smoking.
Right. Then beyond that, you have social and community networks, your family, friends, local connections.
Support system.
Exactly. And then the wider layers encompass things like living and working conditions, access to healthcare, education, work environment. And finally, the outermost layer is the broad socioeconomic, cultural, and environmental conditions.
Wow. So it really shows how these factors layer up. It's not just about your body.
Not at all. It emphasizes that these influences go far beyond just a person's physical state. And because of this complexity, public health involves a huge range of different organizations working together.
Yeah, it's definitely not just the Department of Health, is it?
No way. You've got government bodies like, say, the Food Standards Agency, ensuring food safety. You have local authorities running essential services like sexual health clinics.
Mm-hmm.
And then you have charitable organizations doing vital work like Action on Smoking and Health, ASH Wales, for example, campaigning and providing support. They all play a part.
It takes a village, as they say.
It really does. And to illustrate this complexity, let's maybe take childhood obesity as an example. It's a major modern public health issue.
Okay, how does that play out?
Well, one approach focuses on what might seem like common sense, things like family-based and school-based interventions, trying to influence diet and exercise within those settings rather than immediately jumping to medications or surgery.
Right, trying to change habits early.
Exactly. And this approach highlights the impact of things like, well, increasingly sedentary lifestyles, the constant barrage of food advertising aimed at kids, and even environmental restrictions. Maybe there aren't safe places for kids to play outside anymore.
So tackling the immediate environment.
Yes, but other research suggests that might not be enough on its own. Population-wide approaches things that change the environment for everyone, like making healthy food cheaper and more accessible, or designing communities that encourage walking and cycling. These can actually be much more successful and sustainable in the long run.
So it's about changing the system, not just individual behaviors within the system.
Precisely. It's rarely one simple fix. It's usually a combination of approaches at different levels.
Okay, so we've talked about what health is, the breadth of public health, the inequality issue. Now, let's get practical. How do these big ideas actually get put into practice? Let's maybe zoom out first to some of those foundational global directives, and then maybe zoom right back in, even to our individual genetic makeup. See how health is promoted at all these layers.
Sounds good. A key starting point globally has to be the Ottawa Charter, back in 1986.
Right, I've heard that mentioned as really influential.
It really was. Often described as the foundational document for modern health promotion, it profoundly shifted the conversation.
Yes.
Before Ottawa, a lot of the focus was still on individual responsibility. It's up to you to be healthy. The Charter shifted that focus towards how societal systems, governments, schools, workplaces, our broader environments can actively create and promote health.
So building supportive environment.
Exactly. It presented a much more positive definition of health, focusing on building capacity, strengthening community action, creating those supportive environments, rather than just treating disease after it appears. It was, and honestly still is, a fundamental shift.
And this idea of different levels of influence, societal systems down to the individual, leads us neatly into the different levels of prevention in health promotion, doesn't it?
It does. We often talk about 3 levels: primary, secondary, and tertiary prevention.
Okay, let's break those down. Maybe use an example. You mentioned a family earlier. The Bevins.
Yes, let's use them. So primary prevention. This focuses on the whole population, aiming to prevent problems before they even start, even in people who seem perfectly healthy. Think of Reese, the 27-year-old finance worker living in the city. He feels fine, enjoys life, but maybe eats a lot of fast food, drinks regularly. Perhaps he's overweight, 16 stone 2 pounds in the example.
Okay, so he's not ill, but maybe has some risk factors.
Right. A primary intervention for Reese, and people like him, would be about promoting general healthy eating guidelines, encouraging physical activity, things like broad public health campaigns about 5 a day, or safe drinking limits. It's aimed at everyone.
Got it. Then what's secondary?
Secondary prevention kicks in when someone already shows early signs of illness or has known risk factors. The goal here is to intervene early to prevent the condition from getting worse or progressing. This would apply to David, Reese's uncle. He's 60, a retired miner. Maybe he's had genetic testing that identified a marker for Alzheimer's dementia, and perhaps he started noticing some early memory lapses.
Ah, okay, so the risk is known or symptoms are starting.
Exactly. A secondary intervention here would be focused specifically on him, strategies to slow or prevent the progression of his symptoms. Maybe targeted lifestyle advice, cognitive exercises, early support services.
More targeted than primary. Makes sense. And tertiary?
Tertiary prevention is for people who already have a long-term or enduring condition. The focus shifts to preserving their functioning, managing symptoms, improving their quality of life, and preventing complications. So this fits Lewis, Rice's father. He's 65, a farmer, and he has a provisional Alzheimer's diagnosis. He's been supported by a memory day clinic for 3 years. The goal isn't cure, but to manage the condition effectively and maintain his abilities and well-being for as long as possible, helping him live well with the condition.
Right, managing the impact. That framework, primary, secondary, tertiary, seems really useful for thinking about different health needs.
It is. And that example of dementia really highlights a significant societal burden, doesn't it?
Yeah, the numbers you mentioned earlier were stark. Over 500,000 diagnosed cases in the UK in 2018.
And estimated to rise to over 1 million by 2025. It profoundly impacts quality of life for individuals and families. It strains state finances, puts huge pressure on health resources.
A massive challenge.
But here's where things get really cutting edge and potentially offer new hope.
Genomics.
Okay, Junax, explain that.
So genomics is the study of an organism's complete set of DNA, its genome, that includes all its genes. It's essentially the entire instruction manual for building and maintaining that organism.
The blueprint.
The blueprint. And what's critical, absolutely mind-blowing really, is that just a tiny fraction of variation in the human genome we're talking about, 0.1% difference between people, can actually help predict our susceptibility to certain genetic conditions or predispositions to disease.
Wow, 0.1% makes that much difference.
It can, and we saw a very public example of this with Angelina Jolie, didn't we?
Ah, yes, the preventative surgery.
Well, exactly. Her decision was based on genetic testing that revealed she carried a BRCA1 or BRCA2 gene mutation. This significantly increased her risk of developing breast and ovarian cancer. So she took preventative action based on that genomic information.
That's a powerful illustration of how it can be used.
It really is.
Yeah.
Because genomics offers a truly preventative approach, shifting the paradigm. Think about it. Traditional epidemiology often focuses on tracking disease patterns once they emerge, identifying risk factors in populations. Genomics allows us potentially to determine the precise root cause of a disease at a genetic level, detect inherited conditions much earlier, and maybe even intervene to prevent their progression altogether.
So moving from reactive to proactive.
Precisely. It's considered a major public health breakthrough because it allows for incredibly targeted, personalized, and proactive interventions.
And nurses must play a huge role in this evolving field.
Absolutely critical. Nurses are on the front line. They need to be aware of when genetic testing might be appropriate, so knowing when to refer patients. They need skills in communicating complex genetic information sensitively, adapting it to different cultural backgrounds or language needs.
Yeah, that sounds challenging.
It is. They also act as advocates, ensuring patients make properly informed decisions about testing and what the results mean for them. And of course, they need to continuously update their own knowledge and competency in this field because it's changing so rapidly.
Okay, so we have these levels of prevention. We have this incredible potential with genomics. But there's a big but, isn't there? how do we actually get people to, change their behavior?
The million-dollar question.
Because as you said, simply being given information alone does not make people change. We know this intuitively, right?
We do, and the evidence backs it up. Think about it. A program like SunSmart, promoting sun protection that had pretty clear global benefits. People understood the risk. The action was relatively simple.
Use sunscreen, wear a hat. Got it.
But then look at something like the Eat Well program in the UK, aimed at promoting healthy eating. Despite good intentions and clear information, the uptake, the actual change in eating habits across the population, was much less compelling.
Why the difference?
Well, diet is complex, isn't it? It's tied up with culture, cost, access, habit, emotion. Just knowing you should eat more vegetables doesn't automatically make it happen.
Right. So this points towards needing more personalized, more targeted health promotion, especially for individuals who are already at risk. Just handing out a generic leaflet often isn't going to cut it.
Exactly. People need more than just facts. They need support, they need skills, they need the opportunity to change, and they need the motivation. It's about understanding the how, not just the what.
So are there models or theories that help health professionals understand this better, how to actually facilitate change?
Yes, definitely. Early theories, like the theory of reasoned action, kind of assume people made purely rational decisions about changing their behavior. You weigh the pros and cons, and you act logically.
Sounds sensible, but maybe not always realistic.
Well, that's what more recent thinking suggests. Theorists now argue that impulsive actions, emotions, habits, they all play a massive role too. We're not always perfectly rational actors.
That rings true.
So the big takeaway here isn't just, oh, behavior change is hard. It's that we now have smarter evidence-based frameworks that help us move beyond just telling people what to do. They help us actually understand and tackle the root causes of why people struggle to change.
Okay, like what?
Well, one very practical tool is the COMB model.
COMB, what's that stand for?
It stands for capacity, opportunity, and motivation, which together influence behavior.
Capacity, opportunity, motivation equals behavior. Okay.
It's a framework to work with patients or individuals to identify their specific barriers. So let's say someone wants to eat healthier. Using COMB, you'd explore, do they have the capacity? Like, do they know how to cook healthy meals? Do they understand nutritional information?
Right. The skills and knowledge.
Do they have the opportunity? Can they afford healthy food? Is it easily available where they live and work? Do they have time to prepare it?
Environmental factors.
And crucially, what's their motivation? Do they genuinely want to change? What are their reasons? Are there competing motivations, like comfort eating?
So it helps pinpoint the specific roadblock for that person.
Precisely. And building on that, there's something called the behavioral change wheel. It's a more comprehensive model that works alongside COM.
Okay. How does the wheel work?
It basically synthesizes lots of theories and evidence. It helps practitioners select specific intervention techniques that are most likely to be effective based on the COMB analysis. It even considers broader authoritative social levers, things like policies or regulations that might be needed for enforced change in some areas, like smoking bans, for example.
So it links the individual assessment to potential solutions, including wider policy stuff.
Yes, it connects the micro to the macro.
Now, are there specific communication techniques that are proven to work well in motivating change?
Yes, one approach that's gained significant traction and has a strong evidence base is motivational interviewing.
Motivational interviewing. I've heard of that.
It's often described as a directive, patient-focused approach. The key isn't telling people what to do, but using careful listening and specific types of questioning to enhance the person's own motivation for change, what they call change-oriented self-talk.
So helping them talk themselves into changing.
In a way, yes. It involves techniques like rolling with resistance, not arguing if someone is hesitant, but exploring their reasons. It involves exploring the discrepancy between where they are now and where they want to be their actual versus desired behaviors, and using change-focused questions that encourage them to think about why and how they might change.
Sounds quite collaborative.
It is, and it's strongly supported by professional bodies, like the Royal College of Nursing, as arguably the most tested form of talking intervention to initiate and sustain changes in behavior.
Wow, high praise.
And this collaborative, supportive approach is really distilled into a clinical guideline called Making Every Contact Count, or MECC.
MECC. Okay, what's the core idea there?
It's about health professionals using the routine interactions they have with people, even very brief ones, as an opportunity to talk about health and well-being. Its core principles are really clear and quite powerful. People are ultimately responsible for their own choices. Information alone doesn't cause change. People often have their own solutions within them, and direct persuasion or telling people off is generally ineffective.
So it's not about lecturing.
Not at all. It's about providing support, maybe raising an issue gently, and signposting people towards help if they're interested. MECC Level 1, for example, is designed as a very brief intervention, maybe just 30 seconds to 2 minutes.
That's short.
Yes. Just enough to perhaps plant a seed, offer support, and point someone towards relevant resources or services. It's about opening the door to change, not forcing someone through it.
Okay, so we need these clever models and techniques because just giving information isn't enough. And that maybe links back to what you were saying earlier about social factors, the wider context.
Absolutely. If information alone isn't the answer, we have to look deeper at the social determinants of health. That rainbow model again. And the research here is really consistent. People like Marmot, Wilkinson, Pickett. Their work shows that inequality doesn't just harm those at the very bottom. It affects everyone.
How so?
It creates that gradient we talked about. A gradient of advantages and disadvantages running right across society, impacting health outcomes at every single level. Even people who are relatively well off in an unequal society tend to have worse health outcomes than people at a similar income level in a more equal society.
That's fascinating. Inequality itself is bad for everyone's health.
The evidence strongly suggests so. It seems to increase stress, reduce social cohesion, and impact health through various psychosocial pathways.
And this gradient becomes really stark when we look at specific groups, doesn't it? Like, let's talk about gender.
Yes, definitely. It's important first to distinguish between sex, the biological differences, and gender, which refers to the socially constructed roles, behaviors, expectations, and relationships associated with being male or female.
And these social constructs have real health impacts.
Absolutely. Take education. In many Western countries, girls generally outperform boys in school overall. However, some research suggests girls may face more mathematics anxiety, which can impact their subject choices later on, steering them away from STEM fields. There's also some perception, rightly or wrongly, among some girls that teachers might be more interested in the boys, which can be subtly demotivating. This often contributes to women being overrepresented in sectors like health and social care, while men gravitate more towards science and engineering fields, which often come with higher salaries.
Which leads into employment issues.
Exactly. The gender pay gap is a persistent issue.
Yeah.
One study found UK men aged 49 earning, on average, 45% more than women of the same age. That's huge.
Wow.
And we see concepts like sticky floors, where women get stuck in lower-paid roles, and glass ceilings, invisible barriers preventing promotion, often linked to discrimination.
And caring responsibilities often fall disproportionately on women too, right?
Very much so. Women are frequently the main providers of informal care for children, elderly relatives, or disabled family members. This can lead to reduced sleep, less leisure time, higher stress, and increased risk of poverty, especially if it means working part-time or leaving work altogether. This might partly explain why depression rates tend to be higher in women of childbearing age.
But men face different health risks related to work.
Yes, absolutely. Men are statistically more likely to work in dangerous occupations, construction, mining, fishing, agriculture, facing higher risks of accidents, injuries, and exposure to hazards like toxic chemicals or extreme weather.
So gender shapes health risks in different ways for men and women. It's a complex picture.
Very complex. And then we need to consider the specific health disparities faced by the LGBTQ+ community.
Right. What does the research show there?
Research consistently indicates that LGBTQ+ and non-binary individuals often experience significant discrimination, prejudice, and stigma. This directly contributes to negative mental health outcomes, like higher rates of anxiety, depression, and sadly, suicidal ideation.
That's awful. Discrimination literally making people sick.
It is, and studies also show higher likelihoods of smoking, heavy drinking, and drug use within some parts of the community, sometimes used as coping mechanisms.
So what does this mean for healthcare services?
It highlights a clear need for services to adapt and become more inclusive and sensitive. This could mean things like providing gender-neutral bathroom facilities, ensuring intake forms are inclusive, offering specific appointment times or clinics, and training staff to be knowledgeable and affirming. Ensuring comfortable, safe access for all is crucial.
Definitely. Now, what about migration? That's another huge factor globally.
A massive factor. International migration has increased significantly. And it's important to distinguish between voluntary migration, people moving for work or family, and forced migration, like refugees fleeing conflict or persecution. Both can have complex health effects.
In what ways?
Migrants can sometimes be more susceptible to certain communicable diseases, depending on where they came from and their living conditions. They might face higher risks of occupational hazards if they end up in precarious work. There can also be increased risks of obesity, potentially due to dietary changes, and significant mental health challenges related to the stress of migration, resettlement, discrimination, and trauma.
That's a lot of potential vulnerability.
It is. But crucially, research often identifies deprivation as the single greatest negative impact on migrant health.
Deprivation, more so than specific diseases.
Often, yes, because it's linked to the fundamentals. Poor living conditions, insecure or dangerous work, low income, and real difficulty navigating complex healthcare and social systems in a new country, especially if there are language barriers.
So again, those social determinants are key.
Absolutely. Which means nurses and other health workers have a vital role in trying to minimize those barriers, providing language support, cultural mediation, outreach services to ensure more equitable access to care.
Okay, and what about BAME groups? Black, Asian, and minority ethnic groups. What are some of the specific challenges related to health determinants there?
It's also complex and diverse, of course, not a single experience. But looking broadly, in education, for instance, while there might be initial language barriers for some first-generation migrants, studies often show strong academic performance later on, particularly in secondary education.
Right.
However, challenges can persist. Some data suggests lower success rates in higher education for certain BAME groups compared to their white peers, and sometimes less economic return in terms of salary boost for achieving a university degree.
So qualifications don't always translate equally.
Not always. And in employment, overall, BAME groups tend to have lower employment rates than the white majority. This is sometimes linked, as with women, to unpaid caring responsibilities, but also, unfortunately, to experiences of discrimination in the job market.
So across gender, LGBTQ plus status, migration, ethnicity, we keep coming back to these systemic inequalities impacting health.
We do. And it really brings us back to that provocative question posed by Marmot. Why treat people and send them back to the conditions that made them sick?
It's a powerful challenge, isn't it?
It is. It argues that health promotion strategies focused only on individual behavior change are ultimately going to be limited, maybe even ineffective, if we don't also address the root causes of the inequalities in education, housing, employment, income, and wealth.
So it implies a need for bigger societal changes.
That's the argument. Some researchers explicitly call for policies aimed at reducing these inequalities, potentially through measures like redistributing resources more fairly. It's a political dimension, for sure.
And where does the health professional, like a nurse, fit into that bigger picture?
Well, beyond their direct care and individual health promotion, they have a potentially powerful voice. They see the impacts of inequality firsthand. They can contribute to advocating for social change, lobbying for healthier public policies, using their expertise and experience to highlight the need for action on those wider determinants.
So working at multiple levels, individual, community, and policy.
Exactly. Which brings us nicely to the power of the community itself in promoting health.
Right, shifting from individual or policy to the local level.
Yes, because identifying with the community, feeling like you belong, fulfills a fundamental psychological need. Research shows it leads to greater life satisfaction.
Feeling connected.
And that connection also significantly influences individual health behavior. The norms, the support, the shared activities within a community, they all shape what we do.
So how can we harness that power for health promotion?
One key approach is called community-based participatory research, or CBPR.
CBPR, okay, what does that involve?
It's basically a method, a philosophy really, of involving communities directly in planning, implementing, and evaluating health interventions that they feel will benefit their neighborhood the most. It's not experts coming in and telling the community what they need.
It's collaborative from the start.
Exactly. We've seen some great examples of this working really well. Things like training community members to improve local housing conditions through DIY workshops, or communities coming together to design, develop, and plant shared green spaces, or identifying local champions within the community to encourage physical activity among their peers.
So initiatives driven by the community itself.
That's the key. When the ideas for improvements come from the community, when people feel ownership, the interventions are often far more effective, more culturally relevant, and much more sustainable in the long run. They stick.
But it can't always be easy to get communities engaged, surely, especially in disadvantaged areas.
No, definitely not. There are real barriers. Sometimes individuals in areas facing multiple disadvantages might feel like they're just focused on getting by day to day. They might not see the immediate need or feel they have the energy or power for collective action, even if the statistics show stark differences in life expectancy compared to wealthier areas.
A sense of powerlessness, maybe?
That can be part of it. And another major barrier is when external agencies take a very top-down approach. Experts come in with their predefined solutions based on their assessment of the problems without really engaging with the community's perspective.
And people just switch off.
Often, yes. It can lead to apathy, resentment, a feeling of being done to rather than worked with. And ultimately, the benefits are often minimal because there's no real buy-in or local ownership.
So how do you overcome that? How do you strengthen community action effectively?
It comes down to true community empowerment.
Empowerment. What does that mean in practice?
It means genuinely providing communities with the resources, the support, the skills, and crucially, the power to make changes that they identify as important for their health and lifestyle. It might involve educating individuals about local health risks, but in a way that enables them to generate their own culturally appropriate, sustainable health messages and solutions.
Letting them lead.
Exactly. There's a great example called the Communities That Care approach. It was used successfully to reduce adolescent drug use.
How did it work?
It worked by focusing on smaller, defined communities, identifying their specific risk and protective factors, and then engaging local partners, schools, parents, community groups, young people themselves in choosing and implementing evidence-based strategies they felt would work best locally.
Tailored to the specific community.
Yes. And this kind of approach, focusing on community context and engagement, is also vital when working with migrant communities, for example. Recognizing that they have unique beliefs, networks, and contexts for their health needs and require tailored community-led support.
Can you give us a more concrete scenario?
Sure. Let's imagine a hypothetical neighborhood, maybe called Back Street. It's facing challenges. Some illegal activity, maybe issues with overcrowded housing. There's a deep suspicion of the police among residents. The local council tries running some standard health education sessions, but they're poorly attended. Residents find them unengaging.
Sounds like a tough situation.
It is. Now, for effective change to happen in Backstreet, a top-down approach clearly isn't working. What's needed? Experts need to go in and truly engage the community. Listen to their perspectives on the problems, work with them to identify priorities, and then co-create solutions together. The expert role becomes one of guiding and facilitating, using their knowledge to support the community's own understanding and actions.
A true partnership, building trust first.
Absolutely. Trust is fundamental.
Okay, so we've covered individual change, societal structures, community action. This brings us towards the end, thinking about the practicalities for health professionals. What about ethical leadership and using evidence in all this?
Crucial final pieces. Because health professionals, like nurses for instance, operate across all these levels we've discussed. There's the micro level working with individual patients and families, the meso level engaging with communities and organizations, and the macro level contributing to policy development and global health initiatives.
So they need a broad skill set.
Definitely. They need to integrate knowledge of all those health determinants we've talked about, understand education and behavior change theory, and navigate the complex ethical and political aspects of health promotion.
Let's touch on the ethics first. What guides decision-making?
Well, the work is always underpinned by core ethical principles, things like autonomy respecting individual choice, beneficence acting for the good of others, justice ensuring fairness and equity, and non-maleficence the duty to do no harm.
The cornerstones of medical ethics.
Exactly. And professional codes of conduct, like the Nursing and Midwifery Council Code in the UK, provide a clear ethical framework to help navigate difficult or contentious situations where these principles might conflict.
And what about leadership in this context? Is it just about being in charge?
Not really, especially not in the traditional sense. Modern thinking about leadership in healthcare has evolved quite a lot. We're moving away from purely top-down hierarchical styles
Towards what?
towards approaches like compassionate leadership, which emphasizes empathy, listening, understanding, and creating psychologically safe environments. Or values-based leadership, where decisions align with core ethical values. Or congruent leadership, where a leader's actions genuinely match their words and beliefs. They walk the talk.
So more collaborative and authentic styles.
Yes, these more open, non-blaming, values-driven styles are generally seen as much better suited for the complexities of health promotion. They foster trust, respect, empathy, and genuine collaboration, which we've seen are vital at every level.
And you mentioned distinguishing leadership from management.
Yeah, it's a useful distinction. Management is often seen as more functional planning, organizing, controlling resources, analyzing tasks. Leadership is perhaps broader, setting a vision, inspiring others, synthesizing ideas, fostering change, empowering people. Both are needed, but good leadership is crucial for driving effective health promotion.
Okay, ethics and leadership are key. Now, the final piece, evidence. How does evidence guide practice in health promotion?
This is fundamental. We talk about evidence-based practice, or EBP.
Right, EBP. What does that actually mean in this context?
It's not just about blindly following the latest research study. EBP is generally understood as combining three things: the best available evidence from research, the clinician's own clinical expertise and experience, and crucially, the client's or patient's preferences and values.
So it's a triangle: research, expertise, patient preference.
Exactly. And when we talk about evidence, we mean anything that helps to prove something is or isn't true. Evidence-based means it's supported by a substantial amount of scientific research.
But it's not purely objective science deciding everything.
No, because as we've discussed, personal circumstances, the specific local context, economic factors, patient wishes, they all play a significant role in real-world decision-making too. EBP integrates the research into that complex reality.
And research itself comes in different forms, right? Not just numbers.
Absolutely. We use quantitative studies, often randomized controlled trials, to understand what works, to measure effectiveness, often using numbers and statistics. But we also need qualitative studies, things like in-depth interviews, focus groups, ethnography to explore how someone feels, to understand experiences, perspectives, and the context around an intervention. Both are valuable.
But evaluating health promotion interventions must be really difficult.
It's incredibly challenging. And sometimes, even rigorously tested programs don't show the expected results.
Can you give an example?
Yes, there was a UK program called Families for Health. It was designed to address childhood obesity. It was based on theory, pilot tested, and then evaluated in a large, high-quality, randomized controlled trial.
Sounds promising.
It did. And participants actually reported positive experiences. They liked the program. However, the final results showed that, unfortunately, it was not found to be clinically effective or cost-effective compared to the usual care families received.
Wow, despite being well-designed and liked.
Yes. And this really highlights the complexities.
Yeah.
Why do interventions sometimes fail, even good ones?
Yeah, why?
Well, research in real-world health promotion faces huge challenges. Difficulties recruiting and keeping participants in studies, especially over the long term. Often it's hard to have proper comparison groups. And there's just so many confounding factors that can influence the results. Things like the age or ethnicity of participants, their socioeconomic status, parental weight, other things happening in their lives.
Yeah.
It's really hard to isolate the effect of the intervention itself.
A tough nut to crack experimentally.
Definitely. Which is why we rely heavily on robust evidence syntheses. Things like systematic reviews and umbrella reviews.
What do they do?
They systematically gather, appraise, and synthesize all the relevant high-quality studies on a particular topic. They help give us a clearer, more reliable picture than just looking at single studies. Good reviews are designed to be inclusive, rigorous in their methods, transparent about how they reach conclusions, and accessible to practitioners.
So they pull everything together.
Exactly. For instance, one major evidence synthesis showed that using community health volunteers can significantly improve access to and use of health services in low and middle income countries. That kind of broad evidence is really valuable for policy and practice.
Okay. Wow, we have covered a lot of ground. What a journey. From those really intricate personal definitions of health, right through the profound impact of social inequalities, touching on cutting-edge genomics, the grassroots power of community action. We've seen just how many layers contribute to health and well-being.
It's definitely multi-layered.
And all of it, ideally, should be guided by that compassionate leadership and grounded in solid evidence.
And hopefully, this deep dive wasn't just about spitting out facts. The aim was really to equip you, the listener, with a more multidimensional lens to view health promotion through.
Yeah.
So you can understand that it's far more than just individual choice. It's this dynamic interplay of personal factors, social context, the environment, politics, economics, all tangled together.
Absolutely. So thinking about everything we've unpacked today, those hidden determinants, the power of community, the surprising challenges even with well-intentioned programs, Here's a final thought for you to take away. What's one health initiative happening in your own community or maybe your country that you'll now look at with a perhaps deeper, more critical, and more informed eye after this discussion?
And maybe even what role might you play, whether it's advocating for change, supporting local efforts, or just understanding the complexities better. What role might you play in promoting more equitable and effective health for everyone?
Something to think about. Definitely food for thought. Thank you for joining us on The Deep Dive.